be moderating this session, Medical Cannabis in Transition, Patient Use, Therapeutic Potential, and Global Trends. And here on the stage, we've got a world-class group, and it's always great listening to them. First, we have Dr. William Troutt, the lead medical director of Trulieve. And a lot of you have heard Dr. Troutt speak several occasions, and he's always got something to present and something for us to learn from. And he's going to be talking about product preferences for medical cannabis patients. And then talking about breaking the pill cycle in medical cannabis as a remedy for polypharmacy is Dr. Terrell Newton, my friend. And Dr. Terrell is also the Florida Medical Director of Trulieve and also the Total Pain Relief Medical Director. Dr. Terrell is a wealth of knowledge, and you're going to enjoy hearing him too. Speaking on global perspectives on the future of cannabis, a discussion of regulated cannabis markets is Dr. Calkins and Dr. Block, and they're going to be joining us via the screen. It is quite a pleasure. Dr. Block, I know very well. I've not had the pleasure of meeting Dr. Calkins, but we will enjoy them, and I pray that we have time at the end of the day to ask questions of them, because there's a lot to learn. With all pleasure, I welcome Dr. Troutt. Give him a hand, please.
Thank you so much for that introduction, and thank you all for joining us. So, and first of all, disclaimer, I am the medical director for Trulieve, so for our, again, CME credits, I need to say that. The biggest question I get is, so I have this medical condition, and what product do you recommend? And you know, the truth is, and I think I heard, you know, Dr. Newton probably say this the best once. Somebody asked him, what product is your favorite to recommend for pain? And he said, whatever's best for the patient. And you can't say that any better, right? Because more than what the medical condition is, it's really more about that individual and how they respond to it, what their tolerances are to cannabis medicines, their experience around cannabis medicines, what their daily activities look like. Again, I can go on and on and on about the individual. To really do this presentation well, I actually need about an hour and a half to really jump into all the different ways that I look at individual patients or medical conditions and look at products that I recommend. Let's see if I get that one right. There we go. And another disclaimer, cannabis is not an FDA-approved medication for the treatment of any medical condition. And the truth of the matter is it never will be. It just doesn't fit in that pharmaceutical box. And we get tried, the cannabis industry and the cannabis plant is held to that standard, and it just, it's not what it is. It's got, hundreds of different constituents, hundreds of different actions on the body, and it just does not fit that pharmaceutical FDA model. The way we use cannabis, and the reason we've used cannabis, is based on thousands of years of history and cultures of people getting relief from cannabis with different conditions. And I think understanding how patients use it, why patients use it, is really the best way we get to learning how we can most effectively use cannabis to help our patients. So what I want to do with you all today is share with you some research that we've been working on. It's a survey study looking at, well, first of all, this is very preliminary data. In fact, just finished crunching this portion of the data about 2 weeks ago. And the intent of bringing it here is stimulating dialogue and, again, getting some feedback on it. And as we look to publishing this greater amount of data that we have and we will be observing and collecting. So this is a labor of love. Myself and 3 other PhD social psychologists worked on this survey in our spare time for about 3 years. And I think this is one of the most extensive cannabis surveys looking at patients' knowledge of cannabis use, their frequency, varieties that they use, preferences, terpene preferences, their patterns of use as well, their association with it for using 35 different medical conditions, and then mental, emotional aspects and social aspects. So substitution for other substances, opiate withdrawal, treatment efficacy, long-term healthcare experiences, positive and negative effects, stress, anxiety, depression, self-efficacy, motivation, sleep, and quality of life are the constructs that we were looking at. But what I pulled out for you guys today was looking at the product preferences that patients have associated with specific medical conditions. And we'll look at those, and then I wish we had more time to have a discussion around why that may be the case, but let's please kind of digest this, and then over the next, this evening and tomorrow, if anybody wants to dive deeper into this discussion, I'd really appreciate it, and I think it will help us all. But so the conditions that were most often treated with cannabis. The states that we did collect data in initially were adult use states as well. So, and I've seen data similar to this in other medical states where pain is actually in front of sleep, and that might be one of the reasons there. But 64% reported sleep is the most common condition they use cannabis for, 54% pain, 32% anxiety, 23% stress, and 16% depression. And, you know, as far as discussion aspects around this, I think the first thing that's important to notice is that all of these conditions are conditions that we rely on the patient's subjective perceptions of how those medications are working for them based on our treatments, whether we're changing dosage for them, whether we change different medications for them or not. And, you know, getting into a bigger conversation about pharmaceuticals, double-blind, placebo-controlled studies. I pulled this graph over here, and it's really hard to really pin down this data. This is definitely a very large generalization, but it's looking at responder rates in these conditions with pharmaceutical medicines compared to placebo rates. And the big take-homes here are, number one, even double-blind placebo-controlled studies or medications that go through that process, they're not working for everybody, right? Also, look at the placebo response rates compared to these medications that we're prescribing that are double-blind placebo-controlled studies. And yes, when we do, and I'm not anti-pharmaceutical at all, I think, and I love double-blind placebo-controlled studies, but when we are treating the patient in our office, we are not pulling the placebo effect out of our treatment protocols. And I'm a big believer in belief as well. In my primary care practice, a big part of what I do is getting my patient on board, getting them to believe that our treatments are going to work for them, getting their buy-in. Also with the life-changing type of, exercise and nutrition and all those other things I bring in. And like I said, I think belief is a big part of what we do as clinicians if we really want to get that compliance and the best results out of our patients. So sleep product preferences in this study. And in the past 12 months, how often did you use the following products? And then we made comparisons to the specific medical conditions that they're reporting using it for. And patients that are reporting using cannabis for sleep are reporting preferring edible products much more significantly than other forms of cannabis medicines. And as we know, a lot of that probably has to do with the pharmacokinetics of edibles. And again, the onset and duration times of edibles, right? Lasting up to 8 hours, getting them through that full 8-hour sleep. So not necessarily a surprise there. Sleep variety preferences, cannabis variety preferences. Individuals that report using cannabis for sleep are reporting that they're using indica and indica-dominant types of varieties over the other types much more often. And this is a obviously a hot topic about indica versus sativa, and I would love to spend more time to give my beliefs around that as well. But one thing is for sure is that, again, originally we talked about areas morphology and how we described indicas or defined indicas versus sativas. But now more what we see is that the cultivars are actually producing or selecting and naming these based on the effect that people expect to get from it or looking to get from it. Again, more of that sedative effect from indica type strains and that uplifting more from the sativas type strains as we know. So again, we have that perception around these indica cultivars being more sedative. And I use that in my practice, in setting that intent or that belief system for my patients. We hear about what is the difference between medical use and adult use. And in my mind, it's the intent of why the patient is using it, using that product or that medicine. So, and ritual as well. Cannabis actually, its original use was along with ritual, setting that belief system along with those botanical medicines and botanical products. And then obviously we have this perception that these indica chemovars are higher in terpenes that are believed to be more sedative as well. And we're starting to get scientific physiological evidence that supports that fact. Again, linalool is one of my favorites to tell patients that they can look for in those chemovars that may be more, again, relaxing for them. And we do know that linalool has been shown to have anti-glutamate activity. So if I've got those patients that are real hyperactive, we'll talk to them about trying to settle down their nervous system and using linalool to, again, set that intention. Cannabinoid preferences for sleep. Individuals are reporting that they most often use CBN types of products for sleep. We're seeing that there's that perception now around cannabidiol being more sedative. Again, this comes from anecdotal reports where people talking about aged cannabis had more of a sedative effect than freshly harvested cannabis. Then we found out that CBN is actually a degradative product of THC, so that kind of fit the picture. And there is literature to support that CBD may have more of a sedative entourage effect than some of the other cannabinoids. Again, a lot more studies to come and to be teased out, but it fits the pattern. And then the question is building that perception in our patient's mind as well. How much of this is just the benefit strictly they're getting from it? How much of it is our education that goes into it? How much is marketing of these types of products? I think those are all things that need to be teased out. Individuals that are reporting using cannabis for sleep are reporting using with edible products that are higher in CBD. And this was one that I found a little interesting because, again, CBD alone isn't really known for changing sleep architecture. And, I always think about THC as the one putting people in those deeper layers of sleep. However, there is studies out there showing people reporting better quality of sleep with CBD products. And then, again, those potential synergies between CBD and THC. And Dr. Bone just made a very compelling evidence as well for CBD and sleep. So based on this, I may start providing more education around those one-to-one products for sleep as well. And then is it the other, we've got a lot of other conditions that are associated with sleep, right? So how much of that is, CBD potentially benefiting with those types of conditions also. Product preferences for pain. So individuals reporting using cannabis for pain report using a variety of different products. The only one that was not significant for the association with being used more often with pain were drinks. And there are other studies suggesting patients with pain use multiple products to help treat their pain. This survey study with over 1,300 patients reported that 93% used at least 2 modes of administration and 72% used 3 modes of administration. We've got significant variability in different pain syndromes, right? Different parts of the body, different times of the day, different things that are causing it, and layering of products. Edible with the topical product, we're finding a lot of people that are reporting relief using it in that manner. Different variety preferences for pain. Patients using it for pain are reporting that they're more often using indica dominant, and half indica and half sativa products for pain. And again, is there a perception that indica cultivars are more effective for pain? Or is it the perception that they want to have something that's a little more sedative and a little more relaxing when they are managing pain? And again, we do have that perception that indica chemovars may be higher in relaxing terpenes like myrcene. There is evidence that myrcene has muscle relaxant properties to it. So again, musculoskeletal pain, muscle tension, muscle spasms are a big part of that. So I definitely educate my patients on myrcene to help set that intention as well for why we're using that product and how it can potentially benefit or have that entourage aspect to it. And then cannabinoid preferences for pain. So individuals reporting using cannabis for pain are more often reporting that they're using THC dominant products. And I found this one interesting. I thought CBD was going to show up higher in this association. I definitely recommend CBD and those one-to-ones to my patients that are dealing with pain to get more of that entourage effect, hit more of those systems of the body that are that regulate inflammation and other pathways like that. So then the question is how much is it about that psychoactive contribution to pain relief? There was many individuals suggest that the high or the psychoactive effect is actually a side effect. And that's something that we don't want when we use cannabis products. And I'm not sure that that's absolutely the truth. Again, many of my patients talk about this mental distancing from the pain that comes along with the psychoactive effect. And also, pain isn't just a physical phenomenon. There are emotional and cognitive filters that we process pain through. There are also studies showing that the portions of the brain that regulate pain and the perception and mood and memory around pain and how we perceive pain are hyperactive in individuals that are dealing with pain. And just the thought process about, oh, what if I'm dealing with pain and I can't get to my daughter's graduation, or I can't go do this activity, or I can't get sleep that I have because I got pain. And there's these cyclical processes that take place that heighten the process of pain. So again, I believe that the psychoactive aspect of cannabis is a big part of the how people heal and use cannabis, especially dealing with pain. And then we know those areas of the brain are that do process and regulate these activities highly express CB1 receptors as well. Again, suggesting that this endocannabinoid system is very involved in that process, and we know THC is very active at that receptor. Pain predicting cannabis efficacy. So flower was actually the only form of the medicine that was associated with the individual's perception that it was effective in treating pain, or was the most significant, we shall say, which is another quite interesting because they're using a variety of products. And so what's the discussion around that? Is it because flower is typically administered through inhalation? Is it that immediate response and effect that people are getting from it? Is it that flower also has the greatest amount of all the other constituents that are in it? There's more of a sensory effect from the terpenes with the flower as well. There's, again, high bioavailability with the inhalation of terpenes. So is that part of the reason that we're seeing that association? We also see that terpenes have this polypharmacology that goes along with them. And, oh boy, that happens fast, doesn't it? All right, I'm going to just run through data now. Anxiety product preferences, flower. Individuals are associating flower with the use for anxiety or choosing it more often. Cannabinoid preferences for anxiety, predominantly THC. Again, this was, and we do know that bypassing the first pass metabolism, so we've got a much higher amount of delta 9 THC versus 11 hydroxy. How much does that play in it? We know they affect our receptors differently. Flower THC and cannabis efficacy. Again, flower was the only one that had a significant association with the patient's perception of efficacy of using it for anxiety. And like I said, I really thought I was going to see CBD higher up on that. We do know that CBD is effective for reducing the perception of anxiety that comes along with THC, and I recommend it for that quite often, and I do recommend one-to-ones for people that are dealing with anxiety as well. But doesn't necessarily match the patient perception. So maybe we need to do a better job with education of getting that perception there for the patient to be choosing these types of products that the literature may suggest may be more beneficial. But again, everybody's different. Stress product preferences. Flower, people that report using cannabis for stress are more often reporting that they're using flower. And is it because, again, stress is something that they may consider more transient on a daily basis, so they're looking for that immediate response from it? Or is there a perception that entourage effect is enhancing that sense of well-being? Variety preferences. Patients that report using cannabis for stress more often report using sativa varieties. And I found that one kind of interesting as well, because I thought that they would be, thinking they wanted something that was more relaxing. But maybe it's that people that say that they're dealing with stress, maybe they're perceiving that as more as a mental fatigue or a physical fatigue, and they're looking for something that is potentially a little more uplifting. Again, we do have that perception that these sativa cultivars are higher in terpenes that believed to be less sedative, more motivating. We know limonene has activity at that 5-HT1A receptor, or that serotonin pathway, again, known for motivation and that sense of well-being that goes along with it. Pinene, acetylcholinesterase inhibitor, so increasing those acetylcholine levels in the prefrontal cortex. Again, that clarity that can potentially come with that. So potentially those are the reasons there. Depression product preferences. Patients that report using cannabis for depression predominantly report using forms of inhalation. So flower, vape, and concentrates were all significantly associated with the perception and the use of cannabis for depression. Cannabinoid preferences, predominantly THC for individuals that are using cannabis for depression. And so again, all forms of inhalation were significantly preferred. Like this could be that immediate onset, but concentrates were the most significantly chosen by individuals that report that they're using cannabis for depression. And this is one I've got no answer for whatsoever. So again, if anybody has any discussion points on that, I'd love to discuss that with you further as well. And then in summary, intent, belief, patient preferences are important factors in compliance rates and effectiveness of specific product recommendations. Insightful patient education can focus patient intent, recruit the power of belief, and influence impactful patient preferences. And collecting and understanding data on patient demographics and product preferences is essential to realizing our greatest potential as cannabis clinicians. Thank you. I also gave you guys some bonus slides in there about dosing, as well, and yeah, dosing regimens and other things like that with references.
Let's give him a hand again,